And then the topic today I will present is about the treatment of the purification for the severe acute pancreatitis. We know that it's a hard topic today. I will try my best and to share our experience and some papers just published in the internet. As the first, I want to introduce my hospital, just in the west south of China, and also it's the hometown of the panda. In our hospital, we have more than 5,000 beds, and includes the 200 ICU beds, and also the 33 machines in the different kinds of the types. And in our hospital, we have more than 6 inpatient buildings, and just the CRT and just served all the different buildings, and we just built it a CRT MDT team, which includes the intensive care specialist and nephrologist and the nutritionist and the clinical parasitist. And also we should together to solve some hard questions during the CRT treatment, especially when the metabolities and the drugs removal and some others. So today we will talk something about the CRT for the severe acute pancreatitis. Sometimes the topic is controversial. I want first 3 points to introduce our points. The first, we should to introduce introduction, get something about the mechanism and the characters of the SAP associated with the acute kidney injury. First, we have to, in 26 years ago, with the paper published in the renal failure, and this is a retrospective study about more than 500 SAP patients, and you can see that if the patients complicated with the AKI, the mortalities increased 10 times. So since we can see that the AKI is a very tough thing during the pancreatitis. And also we show some data in our hospital. In this retrospective study, we just included more than 400 the severe acute pancreatitis patients in our ICU. And we can see that with the development of an AKI from the stage 1 to stage 3, the mortality of the patients increased dramatically. So I think that we should pay attention to the patients, how to treat about the SAP with the acute kidney injury. And in the logistic regression analysis, we can see that if the patients with the AKI 3 stage, the patient's mortality rate will increase more than 1.7 times. Interesting is the sense is that if the patients received renal replacement therapy, the mortality rate increased more than 6 times. So in this study, we can see that maybe the CRT treatment is not always a good guide for this kind of patients. For the progression and mechanism of the development of the SAP, sometimes the alcohol or the storms or the lipids will get some the pancreas injury and release enzymes, which can cause an uncontrolled inflammatory cytokine storm, which can cause vascular injury and tissue damage and endotoxemia. And finally, the patient will get the SIRS and MODs. So sometimes maybe in the cytokine storm and some other things, maybe it's the key things we should to think over. And I also reviewed some papers just published about the mechanism of the SAP with AKI. There's still controversial. We know that the kidney and the pancreas are all both the retroperitoneal organs. So sometimes the local retroperitoneal inflammatory cytokine storm also can cause the kidney injury. And sometimes the systemic cytokine storm also can cause the kidney injury. Sometimes some other things like the abdominal compartment syndrome and septic shock and the macro circulation disturbance and energy metabolism disorder also can get something to the kidney injury. And for some basic study, you can see that acute tubular necrosis and about apoptosis of the renal tubular ischemia cells also can give the kidney injury. We can see in the basic study, it's a very interesting thing is that we can see that the kidney injury just in the early stage of the severe acute pancreatitis can occur. We can see that after 1 hour of the occurrence of the severe acute pancreatitis, we can see some kidney impairment occurred. And this study also shows that the mitochondrial dysfunction is sometimes play a key role in the development and the progression of the acute kidney injury. In our hospital, we also do some give some points on the CT scan on the severe acute pancreatitis and acute injury. We found that as the first stage, we can see that the kidney cortex is unclear in the first stage. We can see that the blood the refusion is very poor in the early stage of the pancreatitis. After the control of the inflammatory storm, and we can see that the renal cortex is very clear with the recovery of the urine oil and the decreasement of the creatinine. Okay, the next stop we'll talk something about the indication of CRT for the severe acute pancreatitis without acute kidney injury. In our country, maybe especially in the 10 years ago, some professors showed that maybe the CRT will give some good hands on the treatment and the control of the cytostorm, even without acute kidney injury. So we must just say that CRT should be as a routine treatment of the SAP, and the CRT can improve the outcome of the severe acute pancreatitis. Sometimes the unsolved question is like that. If the CRT can prevent AKI, can increase the mortality and decrease the hospital stay, also the CRT can decrease the incidence of the chronic kidney disease. We should to answer these questions, and we should know CRT whether should be the routine treatment of the SAP even without AKI. We have just reviewed some guidelines of the pancreatitis, especially in Canada, in Italy, and America, and also in Japan and in China. Unfortunately, there's no recommendation about the CRT for the severe acute pancreatitis. And only in China, the CRT is only recommended for the patients with acute kidney injury. And there's no recommendation about the patients only with the pancreatitis without AKI. So in the guidelines international, we can see that there's no evidence about to treat the patients without AKI. But interesting seems that the evidence of the CRT in patients with AKI without AKI is just some optimal findings was found. But the evidence is always from China. So we can see some details about the evidence. And this paper just reviewed all the papers just published about the CRT without AKI for the patients. We can find that the evidence, the level of evidence is very low, and the quality is also very, very low in this kind of papers. Only one prospective cohort study supported the benefits of CRT for the patients even without AKI. Just look and see some interesting papers. In papers, we can see that the study just included just 63 acute pancreatitis. We can see that there's not always the severe, just all the patients is acute pancreatitis, not all the severe acute pancreatitis. And they randomized into the 4 groups of the CRT, the high dose, low dose, and the early CRT and the late CRT. Sometimes we think that is not a good evidence for the patients. And this evidence, we see that I cannot believe the results and the outcomes of these papers. And then in other interesting studies say that just the the authors just treat the patients even without organ dysfunction. So I think that's not meaningful for these kind of patients. More than half the severe acute pancreatitis without organ dysfunction, and we found there's no beneficial about the survival rate. So this paper's evidence quantities are also very low. And this paper is only the prospective, no randomized study. It's some maybe moderate or high level of the evidence level. And this paper shows that with the patients with AKI or not with AKI, the CRT can get a good benefits on the severe acute pancreatitis patients. So we can see some benefits about the CRT for the patients. We can see that the machine organ renal support can give the water removal and the fluid removal. The machine can help our body to keep the fluid balance and to remove the cytokine and keep the electrolyte balance and acid-base balance. However, according to the KDIGO guideline, the dose is very low, so only can give us the EGFR from the range about the 20 to 40 milli per minute. Compared to our own kidney can give the GFR of more than 60, and the cutoff of about 65 is more powerful than the machine. So, in my opinion, if the kidney capacity matches the body's demands, and the kidney can give us the electrolyte balance and the acid balance, also can keep the fluid balance. And furthermore, when the patients receive the aggressive resuscitation, the kidney can also get enough urine oil for these kind of patients. And also the kidney can help us to remove all the metaglobin or cytokine, some special solutions. In this condition, we think that the kidney can play a better role than the CRT machines. So CRT cannot be better than the normal kidney. In this condition, the CRT is not recommended, in my opinion. But sometimes all the things have the two coins. We can see the reverse side of a coin. Sometimes the normal kidney function is not real normal, because some patients into the ICU, admitted to the ICU, we didn't know the history about the kidney function of the patients. So sometimes the baseline of the creatinine always overestimated. And sometimes after the aggressive fluid resuscitation, the serum creatinine is always diluted. So sometimes it's lower than the normal range. And sometimes after the large dose of the diuretics used, the kidney function sometimes was overestimated. So sometimes when the urine oil between 2,000 or 3,000 per day, sometimes the patient also will get the fluid overload, and sometimes the kidney injury occurred when not reaching the KDIGO criterion. So it's always occurred. So we think that if the patients did not reach the KDIGO AKI standard, sometimes not always mean no kidney injury. If the patient did not reach the KDIGO AKI standard criteria, it's not always mean there is no infinite compensatory of the kidney. So sometimes the patient did not reach the KDIGO AKI standard, but the patients will suffer severe hyperkalemia or severe acidosis. Also, sometimes the patient's fluid overload is more than 10% of the body overweight. Sometimes patients also get the cytokine stored, even the urine oil is more than 2,000. Sometimes the patient always suffered about the progressive rhabdomyolysis. Also, it's occurred. So in this condition, the kidney function did not reach the body or the treatment demands. I think this is time for the conventional CRT intervention. So in the 70 AD conference, they have a recommendation of the CRT is that based on the demand of the body and treatment and the the capacity of the kidney function. I think that is maybe the points about how to use the CRT for the patients even without AKI. Also, we have talked something about the education with CRT for the pancreatitis with kidney injury. We have something that unfortunately there's no effective drugs until now for the acute kidney injury. And also, we know that the high morbidity and mortality was found about the patients even with the acute kidney injury. But in our clinical practice, we can see that only a few patients received CRT finally. Not all the patients received CRT. And we also that the controversial things is occurred is always says that the timing of the CRT for severe acute pancreatitis with AKI is controversial. I think that since the 26th, the hot topic of the time of CRT is occurred. We can see the two studies about the IKK1 study and the ELINE study just have dramatically different findings. The IKK1 said that there's negative findings about the early intervention of the CRT. And in the ELINE study, we can see that very good findings about the early intervention of the CRT. So for the IKK1 study, we can see there's no benefits about the early intervention of the CRT. And furthermore, we found that in the late group, just half patients did not receive renal replacement therapy. I think it's a good thing that say that the patients did not to receive early CRT. And in other paper just published in JAMA for the ELINE study, we see that for patients after operation occurred with AKI, the early study can get the survival benefits and also the kidney recovery benefits can have an increase of 15%. It's a very good findings. So we also do a meta-analysis about the timing of the CRT for the patients with AKI in the chronic illness. We found that there's no difference in mortality and no difference in kidney recovery. And we also found that the overtreatment is reported in the early group. So in the recent study, we can also see that for the patients with sepsis with AKI, there's also no good findings about the early treatment of the CRT. And in the large sample about the START AKI study, there's also no benefits about early CRT intervention. And most CRT and more CRT complications will occur in the patients, such as the overtreatment, the hypophosphatemia, and hypotension has occurred. So we can see just in the KDIGO guideline, also see that we should that in the KDIGO for the AKI 2 stage, we should to consider with the timing about the renal replacement therapy for the acute kidney injury patients. And in our local findings, we also find that we just retrospective analysis about 67 the SAP patients with AKI. In our findings, we just found that if we get the CRT intervention earlier, and then the high survival rate can be founded. So there's some controversial about the timing of the CRT for the patients with the pancreatitis with AKI. And then very interesting, just since it's about the papers published lately in last year, just they get the 2 protocol about the delayed CRT protocol. One just is about the delayed protocol about the KDIGO AKI stage and oliguria more than 72 hours, and then the urea more than 40. And another group is that aggressive delayed, just AKI stage and oliguria for the 70 hours, and also with the several fatal complications. Just this findings is very interesting. We found that if we get the more delayed CRT can increase more than 1/3 mortalities in current patients. So we get the point is that for year AKI patients, CRT should be started immediately when fatal complications occurred. And another thing we should do we should to report it is that the therapy also should be started if the patients with oliguria for 72 hours and the urea more than 40 millimoliter, even without any complications. So I think that these points can be used for the pancreatitis with an acute kidney injury. So in our local papers, we also should emphasize on that we should to give the CRT for these patients with AKI, with the fluid overload, and we should always also think that we should to avoid an over treatment in this kind of patients. So in AD-CoI, just also give a very interesting points about the timing, just that we should get the renal replacement therapy for the patients with the metabolic and fluid demands exceeds the total kidney capacity. So we should, in the recent years, we also just focus on some new targets for the pancreatitis with the lipid removal. Just in 10 years ago, we just treat just a pregnant woman with the severe acute pancreatitis with the high limited level. And we use the hyperfusion for this kind of patients. We can dramatically decrease of the lipid, and the patient will get a very good improvement about kidney function and the pancreas. And now nowadays, we use another weapon about the plasma exchange, double filtration plasma exchange for the more high efficiency for the removal of the lipid. For this some picture, you can see that we can from this machine, this technology to remove dramatically about the lipid of this kind of patients. And nowadays we can use different machines for this technology. Not only the Japan machines, also the European machines, also the China machines, and also can do that. Just the Genfron, the machines also can do this kind of technology. So you can use that the patients with the pancreatitis with more than 200 times of the lipid than normal. So we get the 5 times of the double filtration plasma exchange and get a very good prognosis of these kind of patients. So some papers also reported that we use the plasma exchange and also get a decrease of the hospital stay and also the decrease of the recurrence of the pancreatitis. So as also the different and also the similar findings about another paper is also found the rapid reduction of the triglycerides and also prevent the recurrence of the pancreatitis. The findings about is that absorption from the cytokine storm. We know that the pancreatitis sometimes complicated with the septic shock. On these kind of patients, we have also cited some papers published in recently. And the first is about the CPFA, the plasma absorption for the septic shock. From this findings, we get a very just a negative findings. But in this paper, they reported maybe the high dose of the CPFA maybe get more benefits about the septic shock. And last year, recently just the compact 2 studies get also the papers published. They use about 10 liters per day a high dose CPFA for the septic shock patients. For the patients with AKI or not with AKI, we can also do the CRT, conventional CRT such as CHD or CDF for these kind of patients. However, the limitation of the papers is that there's no data about the cytokine level during the CPFA. And in this paper, they found that there's no difference about the mortality between the 2 groups. Another interesting thing is that they found that a high mortality was found. Even the patients, the kidney functions is normal. So this patient, I think in this paper, we got maybe a thinking that if the patients with the normal renal function, we should not do the absorption treatment for these kind of patients. And also there's other papers published about the absorption, about the cytokine storm during some cardiac surgery patients. And the interesting says that if the interleukin 6 between the range about the 100, there's no infection, there's no efficacy about the absorption. And another paper also said that kind of similar findings about if the interleukin 6 and the level from 100 and 150, there's also no difference about the removal, about the absorption. And for the COVID-19 patients, even the interleukin-6 the level range from the 100 to 500, there's also negative findings. So from this, some patients found that the absorption is not effective for the patients with the interleukin-6 from the 100 to 500. But in 20 years ago, there's a paper published very interesting, and the paper reported that if the interleukin-6 is more than 100, the more mortality, sometimes the bad things that occurred for these kind of patients, with the more deaths and the more MODs and the more organ dysfunctions of these kind of patients. So, in my opinion, maybe the interleukin-6 more than 1,000 maybe is the target for the absorption or the plasma absorption for these kind of patients. So we'll talk something about our experience about using the HA 380. So we know that this weapon is just target about the cytokine removal. Also, some paper published that they can remove all different kinds of the interleukin-6 or interleukin-1, some interleukin families. I think it's very important things for our to use this kind of weapon. We just gave one case presentation. It also is just about a female about a severe acute pancreatitis, also with complicated with the septic shock and metabolic acidosis, had a lipidemia, and also the exotonic disorder. And in these patients, because with the high level of the lipid, we use the double filtration plasma exchange for the lipid removal, and also do the hyperabsorption, hyperfusion, and also the CFGF for the treatment. We use the citrate for the anticoagulation. And for these patients, we found that interesting is that the patients, the triglyceride is just decreased dramatically, and also the interleukin-6 decreased dramatically. But the one thing we should be carefully consider is about the decrease of the planets. Sometimes maybe it's not the effect of the absorptor. Maybe some other things just concurred, such as the septic shock also gets the reasons for the decrease of the planet. So the patient just recovered, improved complexly, and with the normal renal function. It's a very good patient for this kind of patient. So in my summary, we have done some key findings on the HA absorptors for these kind of patients. We found that the regional citrate anticoagulation is better than heparin for this kind of patients. It gave us a safer and more effective anticoagulation effect for this kind of patients. And we should to caution that the platelets decreasing is very common and complicated during the HA treatment, even beyond the clotting. And we suggest that if we use the HA 380, we should get the two different protocol. If the patient's platelets is very normal and there's no changes during the treatment, we can use the 2 sets per day. Maybe we can use more than 20 hours per day for the treatment. But if the platelets decreased, especially just more than 15%, just decrease half of the normal the button limit, we should to do 1 set, just maybe 10 hours per day for the absorptor for this kind absorbent for this kind of patients. So this is all the things we should talk something. Is the things we should talk about the pancreatitis treatment. Thanks a lot.